Hello, folks. It's Beth Wright, and I am providing you the podcast for end of life care. And one of the things that about this end of life, or this part of life, I should say, is I've had some experience working with hospice, and it's I have to say it's a most difficult time of life when we're working with patients at the end of life, but it's also one of the most rewarding types of nursing that I've ever done because you're helping people through a most difficult time. And of course, we are all going to experience this both personally and with family and friends. And, personally, it's one of the most difficult things that I've ever been through. I've lost my mother and father and my brother and grandmother and various loved ones, and it is a difficult time of life. But as nurses and providing end of life care, there is so much that we can do for the family, for the patient, to help them through this. And so that's what I wanted to talk with you about. And I know it's a sensitive subject for many people when we're dealing with this type of thing, but I will have to say, there's many times that patients and patients' families, especially patient families, when we're dealing with end of life, I'll see them in the grocery store or somewhere out, and they will remember me and thank me for being there with them and that kind of thing. And people don't forget that, especially when you're with them and walking through this journey and through the most difficult time of life. And I think we definitely have to sensitize ourselves um, when working with end of life patients, because we know, anybody living, they're eventually going to die. We know that, and we have to recognize that. And there's traumatic sudden deaths. That's on one hand, and then we have the chronic illness that leads to imminent, death. And both of them are difficult. Both of them are difficult for families to go through, and for patients, for that matter. And so nurses can make a big impact on the care for end of life patients in either aspect there, and for the families. And you will not be forgotten for love and loving, compassionate care. So again, dying is a stage of living, and it's birth is considered the beginning stage of life, and death is also considered a stage of life as well. And a lot of people feel like that death is a final stage of living, but it is a phase of our lifespan for sure. And some cultures believe that dying is only a stage of living. But death is a natural and normal stage of life. And I think, again, we have to kind of sensitize ourselves to that thinking when we're working with end of life care. The journey is different for every person. I've worked with many dying folks, and I totally agree with that statement. Everybody leaves this stage of life in a different way, and very personal and unique. Difficult for sure, and sensitive for the patient, for the family, and for the friends. Very difficult. And if given the time, the journey can be thought of as a special gift. And I have to tell you, working in hospice. Okay, so the criteria for hospice is the diagnosis should be, if the person's thought to be living 6 months or less. And, you know, many times we would get patients admitted to hospice, and they would die the next day. And although we provided that care and tried to keep those folks as comfortable as possible, there's so much more that can be done for patients and families if they in fact are admitted earlier than a day before the death, or sooner than the day of the death. The family can, we can work with the family, we can work with the patient so that their suffering is controlled. Any pain or symptoms can be managed. So nurses can be a big impact there. If you see patients in the hospital or a nursing home or whatever setting that, you feel like they're declining in health, and they're not going to be here much longer or whatever, encourage hospice care. It is such a special type of care, where that symptom management is done, and work with the family as far as, a social worker. The chaplain can be involved. All disciplines, all multidisciplines or interdisciplines can be involved in whatever that patient needs. And so much can be done for that person, physiologically, spiritually, the psychosocial part of it. So much can be done for a person. So nurses can play a big part in that, and talking with the family and teaching them about hospice care, and getting referrals there so that the hospice staff can come in and talk with them. But walking with that and going through that journey with the family and the friends, even though it's the most difficult time, it is one of the most beautiful times as well, that I have experienced as a nurse and working with families. So we got to talk about the advance directives here. So, the right to decide, that's been around for a long while now, where patients can say, hey, if I'm, have a terminal condition and nothing can be done, then I don't want any heroic measures, developed. And that is the advance directives, as you probably already know, is where the patient decides in advance what their care is going to be. And of course, they can appoint someone to make those decisions on their behalf, or they can make it themselves. So, the advance directives, it's two-part there. You can have the living will, or the durable power of attorney. The living will is where the patient does it themselves, doesn't appoint anybody, or they can appoint someone, a durable power of attorney, for healthcare decisions, to make those decisions on their behalf, or they can do both. The Virginia form has an area where they can do both of those things. They can do the living will and also appoint one or two people to make a decision. Of course, the patient has to be, an adult to do that, and they have to be of sound mind, competent. The durable power of attorney for healthcare decisions also have to be an adult, in order to have their name there. They have to be 18 years or older to have their name there to be a durable power of attorney. And so, we at our end of the healthcare, we definitely honor the advance directives. There's also another type of document that Virginia, the state of Virginia, and I'm pretty sure Tennessee, and Kentucky, all of our neighboring states recognize it. It's called the Five Wishes. Coolest document ever. It covers everything. Like, okay, first of all, the right to decide, the advance directives, it covers that part, and then it has a part where they can tell you what they want in their dying, the last few days of living. For instance, it's got down there that, you want music to be played, you want prayers to be said, you want massages and, things like that. It's got all kinds of little neat things. And then it also has a place where the person can plan their own funeral, who they want, what music they want, who they want to do it, so all that stuff. So it's a pretty cool document, the Five Wishes. If you've never seen it, Google it and take a look at it. But anyway, there's those documents. And of course, we want we got to know about the medical treatment. I mean, it's so important that we know that, and and we got to respect that of what the patient wants. I remember my mom. She would say, "I'm tired. I'm tired of being sick. I don't want to do this anymore." And that's what you hear from a lot of patients, and we got to respect that. And it was hard, very, very hard, as a daughter and being in healthcare. It was difficult to go through that, but we wanted to do what she wanted to do, so we had to follow her wishes, and that's what we did. And so the main thing that you work with the end of life is keeping that patient comfortable. And believe me, we would go to great extent to do that. And it's not just a matter of, doing basic care. It does very much involve basic care needs, but it also involves symptom management. And sometimes that can be real tricky, especially with pain management. With patients, and there's so many symptoms that we're gonna talk about here in a minute that can be difficult to get on top of, but we would go to great lengths to do that, and we did that with a physician. We also had an awesome pharmacist who had end-of-life care experience, and he was incredible to work with to try to meet those patients' needs. So that's a big part of it. Special orders, of course, with hospice, you typically will have a do not resuscitate order, and that they do want comfort measures only, and to do not intubate. And so, the big thing with hospice is, they don't go through a code blue. Now, at any time, the patient they obviously can change their mind. And we had that happen a few times where they would get fearful when it would get kind of close to dying, and they would say, I want everything done. And so hospice would have to be discontinued. And that's fine. That's fine. Again, we respected the patient's wishes to a great, to the full length. And again, those comfort measures, so many times a lot of patients feel like, okay, the doctors mentioned hospice, that means I'm going to die tomorrow. No, it doesn't mean that. And we always talked about the word hospice, that just automatically put into people's minds that, okay, that's my death sentence here. But it's not. Again, those comfort measures, when you think about and you see patients that you're caring for, and they are literally, they're going through chemo or radiation, and, the hope there that there's going to be some type of cure or remission is pretty nil, or the thought is it's just not going to happen, but they continue on through those treatments and things like that, and they're just totally miserable and suffering. Again, mentioning hospice to help them feel better, and be able to live the remaining days of their life symptom free, or as much as possible on the symptom free end, can be of great assistance. And you get some oncologists and that do not like to hear that at all. And then you have, I've worked with some oncologists that were just, they were awesome to work with, and they would tell their patients, we've done all we can, and we really need to think about the palliative care and the hospice care here, so that you don't suffer with what life we've got left. So I mentioned palliative care. So palliative care is definitely involved in here. And what palliative care basically is symptom management. And so, just think about this. Not all, see, patients who are, chronic illness, all patients most likely will have a palliative care need, but not all of those patients are hospice patients. Just because somebody's diagnosed with heart failure or COPD or something like that doesn't mean that they're a hospice candidate. You only get hospice candidate with a 6 months or less diagnosis. Now, what happens if the patient lives longer than the 6 months? It's okay. I mean, you just document things that are happening with the patient. Hospice just doesn't automatically drop it. They continue to monitor the case, and sometimes patients do actually get a little better under hospice care. I had a few patients that were actually discharged from hospice and did quite well for a year, and then had to come back into hospice, but still they say did good. So each case is looked at individually and monitored, of course. But palliative care is where there's a lot of different interdisciplinary strategies that help relieve the symptoms, the suffering, the physical, the mental, and so symptom management is the best way that I've found to describe that. Whereas end of life care takes care of patients, and those last 6 months, if you will, the last weeks and days leading up to the death. And of course, the main goal is to make sure that that patient here leaves this part of stage of life in comfort and to have a dignified and peaceful death. Okay, so barriers to quality end-of-life care. Again, a lot of times because providers aren't educated as far as managing dying patients, that can be part of it. Especially when we're talking about the pain management end. And one huge part is talking about death. A lot of healthcare providers have issues. Of course, it's no fun to talk about that. Nobody likes to talk about it, but it is very difficult. Difficult thing to talk about for sure. But it's something that's got to be done. And it is a barrier because people don't like to communicate bad news. Healthcare providers, a lack of access to palliative care services such as pain management is also a barrier, and just the thoughts of people leaving this life in pain and suffering just breaks my heart, because it doesn't have to be that way. There are too many medicines out there these days that can be used to help with suffering. And so it's a shame to see that, and sometimes we will see that because people are afraid. Providers sometimes are afraid to order a lot of pain medicine or pain management, that kind of thing. And a failure to follow patients' advanced directives, and I've seen this numerous times, and it's just, it's an ethical issue when we deal with that. And the family, and when the patient's not able to speak on their behalf, we've got an advanced directive right there in front of us, but the family comes in and says, I want everything done, I want everything done. I'm going to sue, I'm going to, have a lawsuit. And healthcare providers will sometimes they'll weaken because of that threat, and we should not do that. We need to follow the patient's advanced directives. And I know it's difficult at times, but we owe that to the patient. So again, communicating about death, it's difficult, very, very difficult, and talking about it, I mean, I've been there, done that. My mom would try to talk to me about it. I was like, let's not go there. I don't want to, I don't even want to think about it. And so I was right there, avoiding things, avoiding talking, and, the whole uncertainty about death and fear of death, causes people not to communicate about it. And then, of course, not knowing what to say, is always difficult. And, before discussing, find out what the patient family knows first. So I'll give you some, an example. One of the worst situations that happened to me, I was, had an order to, for hospice for a patient, went to the home, and, so I, when I got there, introduced myself. I'm Beth. I'm the hospice nurse. Hospice? What? What are you doing? What do you mean hospice? So right off, when they said that, I was like, oh no, I am in trouble here. So I said, well, your doctor has ordered hospice, and he wanted me to come and talk to you, see if this would be a service that you'd be interested in. And they said, well, he didn't mention nothing to us about this. And I said, okay, all right, well, let's talk a little bit how how you're feeling and stuff. So how's things going? And so the patient, she was like, I'm not doing good at all. I've just been going downhill. So, she, finding out what they know and what's going on with them. 99% of the time, the patient's going to say to you, I know I'm dying. I'm going down here. I can feel it, and I can't stop this train. And that was the case with this patient. She said, I'm going downhill. I can tell. And I said, well, that's why your doctors ordered us to come in to help you with all that. And it ended up being okay. But boy, I was sure mad at that doctor, because that was really his job to do that, not my job. But I was stuck. I was there, and and so, breaking bad news, I had to say, your heart failure, it's at a stage where there's not much more that can be done other than just keeping you comfortable. And she agreed to that, and we ended up being, really close and everything. But it was, phew, talking about treading water there, I was. But breaking bad news is very, very difficult. It's not good at all to be, and very, very distressing for everybody, the healthcare provider, and mainly the patient as well. So always a good thing if you can in the hospital setting, if a family member is there, if you can be with the doctor when they have to break news, bad news to patients, just to be a support for the patient, is it can be very, very helpful there. So the guidelines for end-of-life care, the patient and family, of course, is the central focus, and we're going to always respect their preferences and listen. Those preferences may change, and so be open to that. They may say, today, I don't want hospice. No, I'm going to, I want to fight this. I want to do everything I can to live longer or whatever, and that's fine. And then the next day they may change their mind. It's not unusual to experience that, and just understand their emotions and decision making and everything, is their world is turned upside down. And so, just being there and being supportive can be of help. And let them know we are here to do what you want us to do. You don't have to go one way or the other. It's can be your, it's completely your decision. Um, Making sure that they have access to care, to quality end of life care. So, talking to them about hospice, and that there can be a great service done for patients with hospice care and end of life care. Um, Provide care that's continuous across the healthcare setting. And what's that meaning? We had times when I had hospice patients that we had contracts with the hospital or nursing homes where the patient could actually go into that setting if the family needed to take a break, or if something needed to go on. So there's contracts there that can help in different healthcare settings, that can help family members. The interdisciplinary approach, I have to tell you, y'all, I mean, I've worked with interdisciplines for all of my nursing career, respiratory therapy and physical therapy, occupational, worked with all of those. But in hospice was where it really came to light about how beautiful it is to work with individuals that care so much about patients, And what would happen, we would have a weekly meeting and talk about our patients and what was needed for those patients. And every discipline would come to the plate, to the table, and ready to do whatever was needed. The social worker, the physical therapy, pharmacy, everybody was on the same table, was on the same page, and it was just absolutely beautiful. It was like the perfect football team out there playing the most perfect football game. I mean, it was just absolutely awesome to see that interdisciplinary approach, and it can be done. I witnessed it. I was a part of it, and it can be done. It should be done, and not just hospice care, but all care. Comfort measures, definitely. That interdisciplinary approach, I need to mention our nursing assistants. They were a huge part of that, and they are also a huge part of that comfort measures, because they would go in and take care of the basic needs, the doing the bad baths. Most of the times they were the ones doing that, taking care of the hygiene needs and things like that. And so comfort measures are, everything from basic care, to the RN taking care of medication needs, other kinds of needs to deal with those, making sure that the patient was comfortable. Also, obviously, we are going to believe in, take care of the cultural beliefs and spiritual needs there, and also financial and bereavement concerns as well. Many patients don't have wills, and so that would be worked out where, somebody could come in and do a living last will and testament for them, or funeral arrangements or things like that. So, lots of things could be taken care of. It's hard to do that when you get a patient one day and they die the next day. And that's why, working through those kinds of things, if you get the patients quicker into hospice, before one day of death, there's so much more that can be done for them and for their family. So walking the journey, you deal with, firsthand knowledge of the terminal diagnosis and nature of the illness and disease. It's a time where the patient is preparing themselves. And, there's definitely grief involved here, anticipatory grief, if you will. Considering the cultural needs and what's available for support systems for the family, understanding needs of a dying patient and the components of a peaceful death. And so a peaceful death, what we're talking about there, is pain and symptom management, clear decision making, preparation for death, completion and contributing to others, and affirmation of the whole person. So that's what we mean by peaceful death there. The development of a trusting nurse-patient relationship. I mean, I've heard so many stories. Intimate stories from patients that were probably never shared with anyone. I mean, you really get close to your patients, and they trust you. And they were my patients, the patients I had. And I felt like a part of their family, especially with that patient, and definitely a trusting relationship develops, and then of course knowledge of hospice and palliative care. So developing that trusting nurse-patient relationship is explaining the condition and the treatment, and teaching about self-care and promoting that self-esteem. Teaching the family members to assist in the care and meeting the needs of that dying patient and the family needs. Now, many times, especially when it's getting closer to the end of life, many times it was more taking care of the family needs than it was of the patient needs, because we kind of got a grip on symptom management and things, and so many times that was the case with meeting needs of that person for sure. Um, when we're thinking about the teaching the family members to assist in care, that can be tricky as well. Some are very eager to do, some are scared to death. And so you kind of got to just test the waters there and see about that kind of thing as you walk through that journey. So the dimensions of end of life. So we got the psychosocial, um, you know, where we got to determine about where the patient and family are at. So we're talking about here the grief process. So the grief process is denial and isolation, anger, bargaining, depression, and acceptance. So where are they? Where's the patient at first off? Where's the family at? And most of the time they're all on different scales, of that stages of the grief. And it's of course they don't go through that in a systematic manner. They can go from denial to depression to acceptance and then back to denial, anger. I mean, it flip-flops, and so you got to kind of test the waters there all the time as far as where is the patient at, and then you got to know where the family is at as well. And helping the patient and family express where they are at can be absolutely healing for them, and it's vital for them. And of course, we got to think about the psychological needs. The patient needs control over the fear of the unknown, the pain and the separation, and the leaving of the loved ones, and the loss of dignity, and the loss of control, and unfinished business. And that sometimes you meet that, and sometimes you don't. But you certainly try to get there. Um, so we got to evaluate how they're coping and the whole dynamics, family dynamics, and support system and resources, and appraise the adequacy of communication with the primary care provider. Is the primary care provider somebody that is talking to them? I mean, I've seen some primary care providers that just kind of drop patients like a hot potato when they're at this stage. Obviously we're going to find out about the advanced directives as well. Now, as death gets closer, the patient may decrease interactions with folks. They may want to be alone more, or with fewer people. They may be depressed, fearful, and anxious. They may be tearful, sad, withdrawn, and quiet. And that's not uncommon. But again, be present, be still, be quiet, be there for your patient. That's the main thing, them knowing that you're there if they do want to talk. The biological part, common symptoms that, or the physiological part, the common symptoms that you're going to experience there is a dyspnea, the breathlessness, the patient gets, having trouble breathing. They're not going to eat. The cachexia is where they've lost so much weight, they've lost body fat, muscle mass, where you can kind of see sunken in areas in the temporal area, the eyes, all over the body. And some disease processes are worse than others with this. But the cachexia you most likely see, and once people start losing that body mass, it's difficult to ever get that back. Nausea, vomiting, coughing, constipation, dry mouth, thirst, skin breakdown, very common, the urticaria or hives, pain, insomnia, fatigue, confusion, anxiety, and depression. These are all very, very common. And our end of is important here. If the symptoms, we've got to check to see, first of all, is the symptoms an adverse effect of the treatment or medications, or is it the disease process? And so what's, the effectiveness of the treatment and medications, and so what are we going to what are we going to do for these different symptoms? And we would have some protocol orders that we would use, that was approved by the medical director, that we would use for each of those types of symptoms there, for sure, to help the patient and control those symptoms. The cultural end, individual differences can exist, obviously, so we can't assume anything. You know what happens when you assume. And so we, need to find out about how open are the patient family to discussions about end-of-life concerns, and how much do they want to know. I've had patients tell me, I don't want to know that. I don't even want to know that. Of course, we respect that. And who is it that you can talk to about the prognosis, about the diagnosis, and who should be included on the end of life discussion, because there's some cultures that believe it should be the male of the family, or it should be the female of the family. So the cultures are different there. And of course, who makes the end of life decision. Some cultures believe that the patient is not the one to do it, that someone that's in higher ranking order in the family does that. What role does the family wish to play in the end-of-life care? And are there any community healers or spiritual leaders that have a role in the decision making? I have seen that happen where a preacher came in and said, you cannot do this, as far as an advance directive, and then the patient changed their mind because that's what he said. So, again, you got to respect what I might not have agreed, but you got to respect what they want. How is death and dying perceived within their culture, and what's the beliefs and values about continuing or withdrawing curative treatment? And then rituals regarding dying, death, and grieving are followed. And so, some churches, they have rites that are done at the end of life, where there is a special ritual that's done, if you will, the rites of death there. So, just finding out what's important to the patient, and trying to meet those needs if at all possible. And spiritual end, of course, is important, and reviewing of accomplishments, meaning of life, the purpose of the existence and possibility of afterlife. Some folks believe in that, and a connectedness to higher being. So a lot of soul searching here when we're talking about the spiritual end at the end of life. So modalities used, obviously active listening, and that means not talking, listening, be present, be still, be quiet. Dealing with cold. A lot of patients are cold a lot, when at the end of life. So keeping them warm, controlling the breathing. So a lot of times, I'm not sure where it's at, but we're dealing with the heavy wet breathing, death rattles, if you will, where you walk into the room and you can hear the fluid in there. So dealing with that can be most difficult. When you hear the death rattles, usually it's not too far away that the patient is not going to be with us. Using distraction can help. Exercise, having the patient lift a can of green beans or something to keep them kind of busy. Heat, massage, all that's good. Educating the patient, positioning is always good, and trying relaxation methods can always be helpful as well. Okay, so the goal of palliative care is to give patients with life-threatening illnesses the best quality of life that they can have by aggressively treating symptoms. Is that true or false? And hopefully you met true. You said true, because it is, in fact, we want to get a grip on the symptoms so that they can have the best quality of life, of what life they've got left. Okay, so the final hours. This is, again, a most difficult time. Most of the time, in my experience, the patient is not really communicating a whole lot with you here. So you're, again, dealing mostly with the family, but providing privacy for that family and or for the patient. And, when you're doing procedures with the patient, even though they're not talking with you as much, talking with them, telling them what's going on, answering questions for the family is very, very important. Expect to be asked when. That's what everybody wants to know. How long do you think it's going to be? And you can never answer that question. You can look at the patient and say, okay, I see some modeling going on. I don't think it's going to be very long, but I don't know. But they're going to ask you when, and it's going to be, asking you a lot. So teaching them about nearing signs that are going to be occurring is really important, so they can be watching for those as well. And of course, anticipate anxiety and emotions, and just be empathetic and patient and compassionate, and be aware the patient and your feelings are normal and natural, and feeling sadness and grief. It's really, really sad, but being a part of that last experience with the patient, being there with them, is such a special gift, to make sure that they are leaving this stage of life, in the best possible way, in a quality way. Ask the patient if there's anybody, if they want near them, if they're, anybody they want to talk to. Do they want you to write something out, call somebody that's important in their life? Be present and hold their hand, and it's okay to say nothing, just to be there. It's a time to allow the patient to cry, to laugh, and it's okay for you to cry and laugh as well. Um, it's time to tell the family, say what you want to say to the patient. Tell them you love them, tell them you forgive them, or ask them to forgive you, whatever the circumstances may be. Let them know they're gonna be missed, and of course providing that comfort, like blankets, personal care needs. You can read to them. I know one patient, she wanted us to read the Bible, a special Bible verse during her last hours there, and that's what we did. Any kind of favorite music that they liked. I know when my mom passed, she loved that song. Gosh, oh Father, where art thou? That movie. In the song, As I Walk Down to the River. She loved to hear my daughter sing that, and as Mom was passing, Jo Beth was singing that song, and it was just an absolute hard time, but beautiful time because of that. So clinical signs of impending death is what you're going to see is everything starts decreasing. We got the urine output starts decreasing, and they start getting cold, and mottled extremities typically starts from their feet and works up. However, it'll surprise you. I remember I went to see one patient. She was just admitted, and I was turned her over to check her back, and oh my gosh, she was all mottled on her back, and I was like, ooh, we're going to be having death here sooner than what I thought. Her legs didn't really mottle as quickly as her back. It's kind of in the lower coccyx area, and I was like, oh gosh, we're going to have death here soon. Blood pressure, pulse starts decreasing. They get to where they cannot swallow, so that can be a biggie. People, especially in our area, you know how we are about food, and people, they don't want anybody to starve, and so I can't tell you how many times I've had to do teaching about, we don't need to feed them because we're going to cause them to aspirate, and then we're going to be this is going to cause this to go quicker. And so we can get the mouth swabs to help with dry mouth and keep stuff on their lips, the chapstick, that kind of thing, on their lips to keep them from feeling like they're so dry there. Bowel and bladder incontinence, is we're going to see that, loss of motion, sensation, and reflexes. Of course, the noisy and irregular respirations, that was what I was talking about a minute ago with your death rattles, and the Cheyne-Stokes breathing where they, have periods of apnea there. And then they'll start breathing. And, one thing that's not on here is it's not uncommon to have people, you almost wonder if are they hallucinating, or are they getting signals from a greater spiritual being? I've seen this many times where, all of a sudden, they're laying there, they're not responding very much, and their hands are lifted up, to the sky, to the ceiling, and, it's amazing what you will experience when you work with end-of-life things, these kinds of things. You'll see, and it'll be, whoa, what's going on there? So anyway, it's like I said, it's amazing. So the physiological end, basically the disease takes over and the body slows down, and eventually stops functioning. And of course, not all symptoms are going to occur at the same time or in any order at all. We're going to see those physical aspects. The appetite starts slowing down. They don't want to eat. They sleep more. They're going to have color changes, and weakness and activity is going to be, weakness is going to be great, and the activity is going to slow down. Restlessness and confusion. Also, again, the urinary output, loss of bladder, bowel function, and breathing changes, congestion in the chest, nausea and vomiting, swelling, you can see edema, circulation of blood and oxygen slows down, and plus many more other things, but depending on what kind of disease process you're dealing with as well. So, interventions: take care of the physiological, psychosocial, cultural, and spiritual needs of the patient as best you can. Teach what to expect. That's the big thing that I think people they appreciate so much when we can be honest with it. And of course, doing that in a loving and compassionate way. And then support for the family once the death has been pronounced, because in the state of Virginia, the hospicarian can pronounce the death. In the hospital setting, they can as well. Any kind of questionable death, there may have to be a coroner involved. I never had to do that when I was working in hospice, but in the ER settings, they may have to do that. And of course, supporting the family, calling family, and working with them, grieving, the grief, and special rituals that need to be done. And we want to think about any kind of knowledge deficits here with the family. We can try to take care of, talking with them about when death has occurred, such as the breathing and the pulse is absent, and the eyes may remain open, and the jaw might remain open, and causing air to escape and things like that. So teaching it's kind of a little freaky for them. So teaching them about that kind of thing, that's completely normal to see at death. And the rigor or stiffness that sets up in 2 to 4 hours after death, and just teaching them about those kinds of things can be helpful. And then, of course, providing post-mortem care, so care of the body. And when we're talking about caring of the body, that means we give them a bath, if you will, the final bath. And what one thing I always did was ask the family, do you want to help with this? And I'll never forget, this one little lady told me, She absolutely, it was the wife of a patient, and she said, absolutely, I want to help because I'm giving him his holy bath. And that just stuck with me. It's like, that's so precious. Um, but anyway, caring for the family during this time, and then, discharging legal responsibilities and death certificate issued and signed, those kinds of things have got to be done. Um, you know, Obviously getting the funeral home involved, and labeling the body, any kind of organ donation arrangements if there was anything involved, and care of other patients. Okay, and of course, preparing that body for discharge, again, doing the postmortem care. We place the body in an anatomical position and replace any dressings, remove tubes. If there is an autopsy because of a coroner case, we would not remove any tubes. But for your hospice patient who's been sick and usually nothing suspicious about a death, then, we're going to remove everything, make sure they're clean. You might put a, um, a brief on the patient, that kind of thing, in case there's any bowel movement or anything that escapes from the patient there. And local law enforcement, or the health department, that kind of thing, if there's a communicable disease. And then again, care of the family, just listening to them express their grief and offer comfort to them. Also, with hospice, the one thing they have is they follow the family a year after the patient's death, with bereavement, and grief counseling there. So that's also another good part of the hospice care. And a lot of times you'll see, obituaries where they mention nurses and family visits, family mentions or praises nursing staff for the care, and many times hospice organizations as well. And if it's possible to attend the funeral, we always try to do that with our patients. Now, I have to say this is important because when you're dealing with death, you're dealing with grief all the time, then it can, do a number on you too. So you got to deal with that. And we did have support each other very much in our hospice agency. And we got to find ways to say goodbye to our patients too, because we get really, really close to them. And that's really, really important to do, to take care of ourselves so we can continue to give the quality care that we need to. Of course, there's going to be legal and ethical concerns at the end of life, or can be. And, the patient continuing further treatment when the diagnosis is life limiting, that's always an ethical concern, or and sometimes legal concern as well. Palliative care versus prolonged treatment, the symptom management versus, are prolonging, the inevitable here to happen. Euthanasia is something that is always a concern with hospice. In the state of Virginia, it is not legal. In some states, it is in the United States. But nursing, as far as nursing is concerned, we do not believe in that, and or at least the American Nurses Association does not. And that's basically where you provide patients enough medicines that's sends them to the next life. Now, that's not to say that there's been times when I've administered medication and we turn the patient or whatever, and next thing you know, they're passed out, or they're gone. They've passed. And certainly wasn't a euthanasia. It was just the death happened with that particular dose of medication. So, definitely legal and ethical concerns there with euthanasia. And then, of course, adequate and quality end-of-life care providers. So making sure that we do have people that are trained in this. There's a lot of training that I got received that I'm so fortunate to have had to provide excellent nursing care to patients at the end of life. And there's a lot to it. There's an art to it, but there's also a science to it when we're dealing with pain management and symptom management and dealing with all the medications, to help with that, and not just medications, other things as well. So I hope you've enjoyed this, and that concludes your podcast.